All right, so now I can see the audio visual. I was not able to see that. So happy evening, everyone. A very good evening. And welcome to the today's YouTube live session where we are going to discuss the radiology questions that were asked in NEET PG 2022. I can totally understand how the students who have appeared for NEET PG 22 are so much bothered by the recall going everywhere. But trust me, guys, these recalls are not meant to make you feel bad. Ki, oh, you got this question wrong. It is more so to understand the concept, to learn from it, especially for the future batches, so that they learn a lesson from what topics have been asked, what are important, how the trend of the questions is changing. So all of that, basically the recall is meant for that and not to make anyone feel bad. And ideally you should not feel bad with the recalls because they are like, they are memory based recall. Nobody knows what the exact question was, right? So just learn out of it to be a good doctor, basically, is what I would say. Okay. So, unfortunately, I won't be able to provide the PDF like I did the last time, all 200 questions, because I was not in the examination hall to know the actual questions. Just give me a minute. Yes, sorry for that interruption. Am I audible now? All right, so let's start with it. And first of all, at the outset, I would like to thank each one of you who has been so kind-hearted and so sweet of you to send all the good messages that how the mnemonics that we discussed in the last few days. We had a dedicated plus course also for the mnemonics crash course, which actually helped many of you in the examination hall. And I'm so humbled and grateful to know that it really helped. And yes, hi everyone here. And we have the Iconic subscription plus subscription, guys, which you can take. Iconic is an academy with Prep Ladder. For the students who just want the test series, you can take up the light subscription. And there are multiple free tests that are going on the platform. You can make the best of those as well. We are going to start with the UPSC CMS revision batch. There was a crash course on mnemonics for both NEET PG and FMG. For students who missed that, can watch the recorded sessions as well. If you missed those live sessions, previous year question bank has been updated, including the FMG question banks. So all the FMG students, please make sure that you see that. And also, we are launching the batch for the next or the NEET PG 2023, and which is going to start on 25th. Okay, which is going to start on 25th of May. It's a 6 months batch basically for NEET PG 2023 starting on 25th May. It will go on till September. So the target is to complete the syllabus by September and then from October to start the revisions. Okay. All right. So let's start with the discussion of the questions. Now looking at the questions, let me tell you that especially in radiology, I think these were the commonly asked topics. So if you are good with the concepts, you've seen the images, then definitely you can get it right. Japna, I know the rest. Congestive heart failure, massive pneumothorax, PET scan. Was there a Spinnaker sales line also? Which of the following is most likely to be seen due to rupture of saccular aneurysm in the brain? Though not a direct radiology question, but we have discussed it in our radiology classes when we were discussing neuroradiology, the various hemorrhages. Oh, thank you so much, Anuja and Japna, for that compliment. So, aneurysm rupture basically leads to subarachnoid hemorrhage, right? We have learned in our classes that what is the most common cause of subarachnoid hemorrhage? It is trauma. Okay, it is trauma which is the most common cause. And what is the most common non-traumatic cause? If the question is that, then it's berry aneurysm rupture, right? So if there's a patient with no history of trauma, coming with the worst headache of life, right, thunderclap headache, we suspect subarachnoid hemorrhage. The first investigation that we do is, next time you can get a question. The patient had saccular aneurysm. On follow-up, now the patient is presenting with thunderclap headache. What is the first investigation? Non-contrast CT in any acute hemorrhage. So basically, it is it is subarachnoid hemorrhage. Subdural hemorrhage is due to rupture of the cortical bridging veins. It's a venous rupture. Extradural hemorrhage is due to rupture of middle meningeal artery. ICH, the intracerebral intraparenchymal hemorrhage, the most common cause is hypertension. The most common site is putamen. So basically, it is the small penetrating arteries, the lenticulostriate branches, that basically are the most common cause of intraparenchymal hemorrhage. Putamen in the basal ganglia is the most common site. Right, so look at this image. Next time, the question can be reversed. Like this can be the image given, and they'll ask you which of these pathology can lead to this condition. Options would be STH, EDH, aneurysm. So when we see the blood in the fissures, right, subarachnoid is blood in the CSF containing spaces, interhemispheric fissure. So basically the blood in the fissures and the cisterns basically would be subarachnoid hemorrhage, trauma or aneurysm rupture. Okay, trauma or aneurysm rupture. And this is what we are seeing here. There is this subtle hyperdensity in the sylvian fissure, interhemispheric fissure. And if you see this image, this is CT angiography. The white CT, bone white, and this is the CT angiography. This is where we are seeing the outpouching from the vessel. ACOM is a very, very common site, right? The anterior communicating artery. These are the ACA. Connecting the two is the ACOM. So ACOM is a very common site for aneurysm. This is where we are seeing the aneurysm, right? And how can we treat the aneurysm? Either by coiling or by clipping. So if the neck is narrow, we can put a coil. This can be done under DSA. Clipping has to be done by a neurosurgeon, right? So that was a very, very important, the question which was asked. Next one. So there were two questions on identifying the investigation. That's why in our classes, I always stress on you should know how to identify the investigations. We should also know radio anatomy because it is absolutely important, right? So what investigation is shown here? We had discussed in our last minute revision as well. Yes. So this is a PET CT. So basically in this image, what do we have is, there are those white bones that we see, white bones with the orange color in the CT scan. That is PET CT. So right, we discussed that if you see a orange colored CT image, actually this has been asked in previous FMG exams also. If you see a orange CT, it is PET CT. We have discussed in our classes, if you see an orange ultrasound image, it is a contrast enhanced ultrasound. If you see a orange MRI image, there's black and white MRI, and you see the orange lighted areas, then it is the bold MRI or the functional MRI, right? So this is the PET CT, which is basically done for staging of cancer, where all the cancer has spread. To look for that, PET CT is now the investigation of choice, right? The SystemEB scan is done for parathyroid adenoma. It is done to localize the parathyroid adenoma. All right. So the answer is PET CT. Next one. This was another question on identification. A middle-aged male presented with acute onset of pain, and what is this investigation? So is it a DSA? Is it an ultrasound Doppler? Is it plethysmography? Or it is MR angiography? We are not seeing the vessels in DSA or MR angiography. We should see the vessels, right? DSA we have discussed many times that if we see the vessel which is black vessel is always a DSA, right? But remember that not always the DSA will be black. So understand the difference. If you see an angiography with the black vessel, it's always a DSA. MR angiography, CT angiography will never show the vessels which are black. So DSA MR angiography is out. Basically, we are seeing the graph here, and this is called as like spectral Doppler. Spectrum matlab graph, and the pattern which is shown here, this is called as triphasic waveform. Upwards, downwards, again upwards flow. Compared to the baseline, it is triphasic flow which is seen in high resistance peripheral arteries like the limb arteries. So this triphasic basically indicates a high resistance artery. Okay, it indicates a high resistance artery. The answer here is ultrasound Doppler. So basically for vascular pathology, especially the peripheral vascular disease, the first investigation that we do is Doppler. Okay, the first investigation that we do is Doppler. This is a similar question that has been asked previously. Like there's a patient with pain in the limb, there's an ulcer. So it's a PVD. What investigation we will do? Ultrasound or Doppler, right? So look at the various waveforms, the first waveform, the second waveform, and the third waveform. Where we see three directions, up, down, again up. This is the normal triphasic waveform in the peripheral arteries. As the resistance decreases, then the waveform becomes biphasic and monophasic. So upwards and downwards, that is what we are seeing. This is a biphasic waveform. When it's just above the baseline, it's not going down only one direction. This is monophasic waveform. So remember that the veins normally show the monophasic waveform. An artery which is stenosed significantly, surrounding me, it has formed the collaterals. The collaterals show the monophasic waveform because they are low resistance. So collaterals show monophasic, veins show monophasic waveform. So this was the triphasic waveform that was shown. Next question. Now coming to the genitourinary part, what questions were asked? So a delayed IVU is shown. What is the most likely diagnosis? Now the options at Staghorn calculus, putty kidney, renal cyst, and the pelvic-ureteric junction obstruction. Now what do we see here? Most important, it's given that it's an IVU image. Now whenever there is calcification, remember we have discussed calcification can be seen on a plain X-ray. More sensitive than that is a non-contrast CT. We do not need contrast basically to visualize calcification. So Staghorn calculus is calcification, putty kidney is calcification. They would not give you an IVU image like, for that. Last time, the question in NEET PG 21, there was putty kidney ka image that was given. A plain X-ray KUB. It also mentioned the important clue that the patient has sterile pyuria. Now this time it is delayed IVU image. Why is the importance of delayed? Because basically you see that this is after 20 minutes. That means it is a delayed IVU image. And we are seeing that the calyces are dilated, the pelvis is dilated, but we don't see the ureter. Look at the right one. The pelvic calyceal system is there and the ureter is also seen. That means there's a continuity. Here we cannot see the ureter on the left side, means that there is an obstruction here. Okay, there is an obstruction here and that is why it's not going ahead. Okay, that is why it's not going ahead. So this is the PUJ obstruction. Okay, this is the PUJ obstruction. Anyone remembers from our mnemonics classes, named surgery, what surgery do we do for PUJ obstruction? Remember, the pelvis and the ureter are separated away. They want to say hi to each other. It is your Anderson-Heinz operation, right? Anderson-Heinz operation. Son, it's seen in a child. So that is an Anderson-Heinz operation. Okay, Anderson-Heinz operation. Okay. Going to the next one. Okay, going to the next one. Look at this image again. Look at the normal pelvic calyceal system and look at the dilated calyces. This is the PUJ obstruction with the hydronephrosis on the right side. Okay, on the right side. Okay. Now look at this image and look at this image. These are the plain X-ray KUBs. These are not IVP. This is plain X-ray KUB. If you see a calcification following the calyces, okay, that is the Staghorn calculus. Okay, that's the Staghorn calculus. If you see that the entire kidney, including the parenchyma, is calcified, then this is the putty kidney. Okay, that's the putty kidney. So this is the Staghorn calculus. Okay, this is the Staghorn calculus, and this is the putty kidney, where the entire kidney is calcified, the parenchyma is calcified. Now that's what I said, because the question mentioned that it's a delayed IVU, right? As far as I have got to know, but that's why I said just learn the concepts out of these recalls, because they are memory based, right? If it was an X-ray image, then Staghorn. If it is mentioned it's a delayed IVU, then you should think of PUJ. Okay. So plain X-ray KUV, basically you will not see the other pelvic calyceal system. How will you identify was it a plain X-ray or a IVU? If the other is also seen, then it's your IVP. Okay. If the other system is also seen, then it's the IVP. Okay. All right, going to the next from the nephroradiology, another important. So a lot of nephro was also there. 6 years old child, recurrent UTI. I think this is very, very important clue to diagnose a case of VUR. Classical, a child with recurrent UTI. The first thing that we think of is the first thing that that comes to our mind is VUR, vesico-ureteric reflux. And when it is given that MCU of the patient is given, so that's another important clue that MCU is the investigation of choice for VUR. We have discussed in our classes, MCU is the investigation of choice for which two conditions. What was the trick to remember? Whiting cystourethrogram, VU and VU, that is VUR and the PUV, which also has your UV or VU. So VUR and the PUV, that is the posterior urethral valve, are the two conditions where VCUG or MCU, that mean the same thing, are the investigation of choice. Because we want the bladder to contract, the increased pressure leads to the reflux. So you can see there is hydroureter, there is hydronephrosis. This is like grade 5 VUR on this image, right? Can extra edge question, next time it can be asked. In this patient, on follow-up, to see the scar in the kidney, what scan is done to see how much scarring is occurring in the kidney? What would be answer to that in that case? To look at the scarring in the kidney in the follow-up of the child with VUR, what scan do we do? Very good. It is DMSA scan. Remember S for our mnemonic, it is the scar. So it's a DMSA scan which is done to look for the scarring. All right. So this is VUR. The grades of the VUR, when you have hydroureter, hydronephrosis, gross dilatation, ureteral tortuosity, it is the grade 5. Okay, that's the grade 5. So remember basically that the dilatation of the ureter or the hydronephrosis, it starts from grade 3, mild, moderate, severe. Okay, up till 2, there is no hydronephrosis or hydroureter. Okay. GFR, DTPA, both GFR and tubule anuja, that's your MAG 3 scan. Okay, that's your MAG 3. Yes, Preeti, what happened? Okay, so a lot of, again, uroradiology. Tell me, what is this? 30-year-old with motor vehicle accident presented with stable vitals, unable to pass urine. Okay, unable to pass urine. Then, will I be starting PG classes for radiology residents? Pretty no plans yet. Honestly, I have not thought about it yet. The NEET PG aspirants themselves have kept me so busy that I've not got time to think about anything else yet. He has blood at the urethral meatus. Very, very important clue. Very, very important clue. That is the urethral injury ka clue hai. RGU was performed. What is the most likely site? Okay, what is the most likely site of urethral injury? See, now the image that was given basically had fractures, pelvic fractures, like you see in this image. There is this fracture here, superior pubic ramus, both sides. So basically, there is this pelvic fracture, and associated with pelvic fracture is generally your posterior urethral injury, right? There is blood at the urethral meatus, unable to pass the urine. Those are the histories. And pelvic fracture is important. And what do we see here in RGU? That the contrast is going out. That is extravasation of the contrast, which is this posterior urethra, which is membranous urethra. Based on the history also, Penile urethra is basically anterior. Spongy is the term for anterior. Bulbar is also anterior. Let's have a look at the parts of the urethra. See, the close to the bladder is the prostatic urethra. The narrowest part that we see, that's the membranous urethra. Then we have the bulbar urethra and the penile urethra, which is basically the anterior or the spongy urethra. So here there is this narrowing in the membranous urethra, right? So this is the membranous urethra, basically the posterior urethra. That is the cheat code that you could use कि अगर ऐसा history है pelvic fracture, posterior urethra, membranous urethra will be the answer, right? So what do we do in these patients? The first thing, is it putting the Foley's or doing a RGU? What should be done first? First is RGU or first is putting the Foley's? Never put the Foley's first, but the RGU is done basically to evaluate the urethral injury, whether it is partial or it is complete urethral injury. Partial matlab partial wall rupture हुआ है, but still the contrast will be seen going into the bladder. Complete matlab there is complete transaction, the contrast will not go into the bladder. So we don't put the Foley's first because it can injure the partial injured urethra and convert it into a complete injury. So first is always to assess the extent of the injury with RGU, and then we put the Foley's. Sometimes suprapubic cystostomy might also be required when we cannot put the Foley's, right? So remember, urethral injury, basically what are the clinical clues? There is gross hematuria, blood at the urethral meatus, there can be scrotal hematoma, inability to void, and especially if the patient has pelvic fractures, straddle injury, self-instrumentation ka history, we should always keep urethral injury in mind. This is how the normal IGU is, right? And this is the abnormal with the extravasation. Okay, this is the abnormal with extravasation. Okay? So do not pass the Foley's until the RUG, that is RGU, is completed. Okay, until the RGU is completed. All right, let's go to the next question. I think this is a topic. This is a topic that is the favorite with the examiners, the uterine anomalies, right? The uterine anomalies. 22-year-old with primary infertility underwent HSG examination. What is the diagnosis? I will put this question as a sort of difficult question because it's confusing. If it's a unicornuate uterus, then it is easy. But if they are asking you to differentiate septate and bicornuate, then it is a bit confusing. So remember the concept here. When it is uterine didelphys, now what are uterine anomalies? The female reproductive tract develops from the Mullerian duct, right and left. The two develop, then they come in the midline, they fuse, and then the septum goes away and it forms one complete uterine cavity with a smooth wall. If the two do not fuse at all, they are entirely separate. So that will be uterus didelphys. It is no fusion at all, is uterus didelphys. So there are two uterus, two cervix that would be seen. So we need to cannulate both the cervix. So basically uterus didelphys will have two cannulas. Okay, it will have two cannulas. The next that we have is septate, bicornuate and unicornuate. Unicornuate will be deviated to one side and it's a banana uterus. Bicornuate is a problem with the fusion. It's a partial fusion defect. It's a partial fusion defect. In septate, the fusion is complete, but the septum is not removed. So basically here the fusion is complete. Now understand this concept that when it's a fusion defect, the outer surface of the uterus will also be separate. When the fusion is complete, the outer surface of the uterus would be smooth. That is why to categorize the uterine anomaly, we need to have a look at the outer surface, and that is why HSG is not a very good modality. Because in HSG, we see only the endometrial cavity. We don't see the outer surface. So that's why ultrasound is better. More than ultrasound, better is MRI. And the gold standard is hysteroscopy plus laparoscopy. You see the inner uterine cavity and the outside the surface as well. Both combined is the gold standard. So here, because we are only seeing the two cornu, it could be septate also or it could be bicornuate also. Ideally, we differentiate these based on the outer surface of the uterus. Here we are seeing only the endometrial cavity. So it is said that if the two cornu are very close together, that means the fusion is complete. So it's a septate uterus. Now I have not seen the image myself, but I'm just telling you the concept that how will you differentiate it septate or bicornuate. If they are close together, it is septate because in septate the fusion is complete. That means they have come in the midline. Bicornuate will have a wider angle, more than 105. Here it is said to be less than 70. Okay, but this is not foolproof. So remember this concept. Now this is the MRI, septate versus bicornuate. Look at this. There are two cornu that we see in the HSG. This is the only thing that we see in HSG. We don't see the outer surface, whether it is like this or it is like this. MRI shows the outer surface. Okay, MRI shows the outer surface which is smooth. So this becomes your septate uterus. The smooth outer surface tells me that it's not a fusion defect, right? It's not a fusion defect. So this is septate. Remember, septate is smooth. Septate is smooth. S for S. When you have the cornu which is widely separated like this is an obvious wala bicornuate. But in the practice, we do not always get like this, like the textbook image. There is a confusion between septate and bicornuate. So when we do MRI, we have the two endometrial cavities. The outer surface is also separate. You can see each has its own outer surface. So this is a fusion defect. So this is bicornuate uterus. Remember, bicornuate will be bifid outer surface. Septate will be smooth outer surface. Okay, so MRI is a very good investigation basically to identify the uterine anomalies. HSG is not a good modality. If they have given you the classical image where they are very close together, it's a septate. If they are very far away like this, then it's a bicornuate. Okay, otherwise it's a bit difficult to differentiate the two. All right, let's go to the next question now. 11-month-old child with recurrent abdominal pain, mass can be felt, barium enema study was done. What was the diagnosis? See, first of all, they have given you that it's a barium enema and it's a 11-month-old child. Duodenal atresia presents with bilious vomiting in the newborn itself, right? So 11-month-old mein nahi aayega. Okay. Second, barium enema, duodenal atresia ke liye we will not do barium enema. For malrotation, it will not be barium enema. So either it is intussusception or volvulus. Volvulus is generally seen in the elderly. So without looking at the image, if you want to take a logical guess, this is how you can, take a guess based on the clinical profile of the patient. Now, a child is given with recurrent abdominal pain. That's a classical age, child, weaning age group, the lymphoid hyperplasia that happens, and that leads to the, so there's a palpable mass in the lower abdomen. This is the classical history that will be given in intussusception. Sausage-shaped mass, that all is given. Okay. So thank you, Japna, for giving that history. So this is a barium enema that is there. And there is this classical claw sign. So what happens in intussusception? One bowel going inside the other bowel. When we do the barium enema, barium goes up, barium goes up. At the point of intussusception, the barium cannot go ahead because it is blocked by the intussusceptum. So this barium then forms a claw around the intussusceptum. So that is called as claw sign. Can anyone tell me the another sign in barium enema that was asked in the previous NEET PG exam? So you can see that the topics are definitely repeated. A lesson for the future aspirants. Master the previously asked topics. You've seen the topics are easy. It is the options which become tricky. So mastering the topic is very, very important. Don't just master the questions. So in the previous exam, the another sign that is seen in barium enema is if the barium goes in between the two, the intussusceptum and the intussuscipiens, there is some space. So the barium goes outlining the intussusceptum like a coiled spring. Right, so this is what you would see. This is the coiled spring sign. This was a question asked in the previous NEET PG. Coiled spring sign is seen in intersusception. It is the barium outlining the intersuscept. And what sign do we see here in ultrasound or CT? Intersusceptum, intersuscipiens, inner bowel, outer bowel. That is the target sign or the donut sign. Okay, that's the target or the donut. Next time the question would be, what is the management, the first management in this patient? It's not surgery. It is either hydrostatic or the pneumatic, that is air reduction of the intersusception. We push the air or saline can push the intersusceptum out. So that is the first management. Only if the intersusception is recurring again and again, then we go for surgery. Okay, then we go for surgery. And also remember that Meckel's is one of the important etiologies for predisposing to intersusception. All right. So everybody is clear with this intersusception. Claw sign, coil spring sign is what we see. Target sign, donut sign. The investigation of choice is ultrasound because it has no radiation and it can show the target or donut sign. So in ultrasound is the investigation of choice. Okay. Next one. So this is what the ultrasound is showing, the inner bowel and the outer bowel. That is the target or the donut sign, right? How a donut is inner and outer circle, target or the donut sign. All right. Never mind, Japna, we have room for many mistakes to make in the examination. It's not that to get a good rank, you need to have, your mark all the answers correct. There's a lot of room to make mistakes. So don't worry on that front. Okay, let's go to the next question. So that was about the abdominal radiology. Basically, we saw genitourinary and we saw the GIT wala. Now coming to the chest radiology, what questions were there in chest radiology? 35-year-old, fever, expectoration, difficulty breathing, HRCT performed. What is the diagnosis? This is the classical air bronchogram sign. Now, what are we seeing here is the air bronchogram sign. We have discussed this so many times in our class. We have discussed the MCQ also. Air bronchogram sign is always a suggestive of parenchymal pathology or a pleural pathology. It tells you that the pathology is parenchymal. What is air bronchogram? See, normally what happens, the lungs and the bronchi. How are the normal lungs on CT scan? How are the normal lungs on CT scan? Black, because they contain air. How is the normal bronchi on CT scan? Again, black, because they contain air. Now, when there is consolidation means solid. The alveoli are filled with something which is more dense, going towards solid. So that will become white because as the density increases, the structure becomes white. The lungs become white. Okay, the lungs become white. Bronchi are still black. Okay, bronchi are still black. So what do we see is normally the lung is also black, the bronchi are also black. So both black and black, we cannot differentiate lung and the bronchi. When in consolidation, the alveoli, the lungs become white and through that we see the black bronchi, right? Through that we see the black bronchi. So the white lung basically gives a good contrast to the black bronchi. So a prerequisite for air bronchogram sign is the lung parenchyma should be white and the bronchi should be black. That means air containing. If you have the white lung and the bronchi also become white because of mucus, anything, then we will not be able to identify the bronchi, right? I hope you are understanding. When everything is of the same color, you cannot differentiate the two structures in that color if they are of the same color. If I change the color, right, if I change the color of the bronchi now, this is the white lung, these are the black bronchi, then I'll be able to see the bronchi. So this is air bronchogram sign, which is always suggestive of parenchymal pathology because the lung parenchyma is white. So pleural effusion is out, mediastinal mass is out. We have discussed a similar question in our last minute revision, the plus course. Diaphragmatic hernia is out. The only parenchymal pathology that we are seeing here is consolidation, right? It's the only parenchymal pathology. The extra parenchymal pathologies will not show the air bronchogram. Okay, they will not show the air bronchogram. So this is the white lung and these are the black bronchi which are going through it. So this is consolidation. It could be any cause of consolidation: pneumonia, pulmonary edema, hyaline membrane disease, cancer, bronchoalveolar carcinoma specifically, that can come with air bronchogram. Okay. Let's go to the next one. I don't think any exam can be complete without pneumothorax and pneumoperitoneum. Even FMG students, please make a note of it. I think the examiners are given the guidelines कि ये दोनों के बगैर the paper cannot be completed. Right? So every exam will have questions on that. Be it NEET PG, be it INICT or be it FMG. So 30-year-old, again an accident, bruises, pulses 120, tachycardia, there is hypotension, tachypnea, and you see the image. So whenever with the chest x-ray you are given this history, you should always start thinking of pneumothorax even without looking at the image. Okay? And right. So what do you see here? Now see that what is happening is, this is the black color, right? This is all black that we are seeing. Let me zoom the image. Where did it go? All right. So look at the image. This is very black. This is jet black. Why this is not an inflated lung? Why this is pneumothorax? Because you don't see the bronchovascular markings. In a normal lung, you would see the vessels going through it. You would see the white vessels. Here you are not seeing any vessels. That means this air is outside the lung. So this is pneumothorax. This is the collapsed lung. Okay, this is a collapsed lung. Okay. If the vitals were stable in the exam, all right. So as I said, it's a memory-based recall. Now, whatever might be, whatever might be the patient, stable or unstable. Pleurodesis तो absolutely answer नहीं होगा. When do we do pleurodesis? Basically, effacing, obscuring the pleural space. In cancer patients, frequently done if there is recurrent pleural effusion. Let's say, for example, there's a patient of CA breast having recurrent malignant pleural effusion. Every time we are draining, tapping the fluid, again the fluid is accumulating. So we block the pleural space, right? Talc वगैरह use करते हैं, ठीक है? Pericardiocentesis. Pericardio means pericardium में से fluid निकालना. That will be done for pericardial effusion, right? That would be for pericardial effusion. So it is the thoracotomy. Will we do a thoracotomy, which is like a major surgery here in pneumothorax? No. So ideally, if there would have been an option like a wide bore needle, तो हम वो कर सकते थे. नहीं तो हम chest tube डाल सकते हैं, drain, ICD drain डाल सकते हैं basically to remove the air, right? To remove the air. So pneumothorax is very important. Okay, it's very important and frequently asked. ठीक है? Difference between pneumo and hemo. Pneumo is air, so it will be black. Hemo is blood, it's a fluid, so it will look like pleural effusion. It will be more white. Okay, it will be more white. So this is for pneumothorax. And remember, the chest tube is placed according to the guidelines in the 5th intercostal space in adult and in the 2nd intercostal space in a child. Okay. I really don't know what the options were given. ठीक है? अगर ऑप्शन में रहेगा तो ही मार्क करेंगे, अपने हिसाब से तो मार्क नहीं कर सकते, राइट? ठीक है, द नेक्स्ट वन. So two pneumos, pneumothorax, pneumoperitoneum, absolutely important. Whatever is pneumo and calcification related, basically remember in radiology that is important. And you can see how the weightage of radiology is increasing in the questions, either direct or an indirect clue that helps you come to the diagnosis. So this is the image which is showing the free air under the diaphragm, right? There is the free air under the diaphragm. This is pneumoperitoneum, right? This is pneumoperitoneum, the free air under the diaphragm. Most common cause pneumoperitoneum is bowel perforation, though always that is not the case. Okay, though always that is not the case. It could be because of post-operative also. It could be pneumothorax, pneumomediastinum extending down. In pneumoperitoneum, basically we do resuscitation and exploratory laparotomy, considering bowel perforation. So we need to treat that. So resuscitation and exploratory laparotomy. Okay, so here the blood pressure was 90/80. So the vitals unstable. That is what we need to modify here. Okay. All right. Going to the next one. So now when it is given that the patient has severe abdominal pain and vomiting, you should always focus first on the abdomen wala part, right? So that you do not confuse with pneumomediastinum. So, next one. Now coming to few images that were given. I'll just focus on the radiology images, like example of how in other subject questions like medicine, orthopedic, surgery, OBGY, radiology could help you answer the question. Okay? So if there's an image, I don't know what kind of image was there, but if you see bilateral perihilar opacities like this, if you see bilateral perihilar opacities like this, with relative sparing of the apices, with relative sparing of the costophrenic angle, that is basically the bat wing appearance. Okay, that is the bat wing appearance of pulmonary edema. And pulmonary edema is generally, caused by, this was a hypertensive patient, I believe, congestive heart failure, the left heart failure to be more specific. So when the left heart fails, the back pressure going to the left atrium, going to pulmonary veins, basically the lungs get congested. So that is pulmonary edema. That is bat wing appearance. Again, we have discussed this. Remember that even pulmonary edema will show the air bronchogram sign because it's a parenchymal pathology where the lung is becoming white. Okay? So this was another bat wing appearance. Second, like in this case, how radiology could help you answer the keyword chest x-ray showing bilateral lymphadenopathy, bilateral hilar lymphadenopathy. That is gonna be your sarcoidosis. So many times we have discussed this question. Whenever you see bilateral hilar lymphadenopathy, large potato nodes, the stage 1 of sarcoidosis is mediastinal lymphadenopathy. It is sarcoidosis. What bodies are seen in sarcoidosis? Are mnemonic SAR, that is Schaumann bodies, asteroid bodies, and reticulate bodies. Right? Schaumann, asteroid, and reticulate. Okay? Why not TB? Because TB is not generally bilateral, it is unilateral asymmetrical hilar lymphadenopathy. Okay? And I think you were given another history also. What was the other history that pointed to sarcoidosis? Was there a history of facial palsy? Somewhere I got to know that there was history of facial palsy also. Or anything related to parotid gland enlargement. Uveitis history was there. Okay. So that is another clue. TB can also have that. Facial palsy bhi tha. Okay, the facial nerve involvement. So remember sarcoidosis, Lyme's disease, these you should always keep in the differentials of facial nerve palsy. Sarcoidosis, bilateral hilar lymph node, Lyme's disease would be classical like going to a mountain area, camping, tick bite wala, basically the Borrelia burgdorferi, target rash, right, the bullseye lesion, all that would be your Lyme's. So sarcoid and Lyme should always be in the differentials of facial nerve palsy. Okay? That is why it's not TB, it is sarcoidosis. Remember, it has increased ACE levels, it has hypercalcemia that is seen. Now look at this one. So these are the bulky hila which are basically showing the bilateral lymph nodes, that is sarcoid. And remember in HRCT, what is the most important finding in HRCT? What is the most important finding in HRCT? The keyword, along the fissure, there are those nodules. So fissural nodularity, because basically in sarcoid, there are lymphatic, perilymphatic nodules. There is lymphatic spread of the nodules. Fissures ke along, bronchovascular ke along, subpleural nodules, that is what is seen. So fissural nodularity is a very important feature. If you see that on HRCT, again remember sarcoidosis. Okay, again remember sarcoidosis. Okay. Going to the next one, again an example of a question. Even if the image was difficult or we could not identify, the history should be good enough to make a diagnosis. 45-year-old, recurrent swelling on one side, afraid of eating food as it worsens the swelling. What is the imaging? Whenever you have a swelling which increases when a patient is having food, let's say बहुत बार तो कोई सार food का history होगा, because it stimulates the salivary gland secretion. Okay, the food increases the salivary secretion. If there is a stone in the duct that is blocking the secretions, the gland will enlarge and that will cause the swelling. So whenever you have this history, a swelling which increases with eating, we should keep this salivary gland calculus silolithiasis in the options, and the answer will be silolithiasis. So in the submandibular region, basically there is this calcification. Again, calcification ka question. So remember this point in radiology, wherever there is calcification, wherever there is air, these are frequently asked. Basically, they expect you to identify how calcification looks like and how air looks like, X-ray and CT. So the answer is silolithiasis. Okay, silolithiasis. Previous NEET PG, similar question on the salivary gland calculus. I think 2-3 years back it was asked. That is if the calculus is inner to the mandible, it is a submandibular calculus. If it is present outside, then it's your parotid calculus. Because parotid idhar hai, submandibular is inside the mandible. That is how we'll differentiate submandibular from parotid. Okay. So look at this one. Is it submandibular or is it parotid? Now this is a CT scan image basically, right? This is the mandible. The stone is medial, that is inner of the mandible. This is the submandibular. This is where we have the parotid, at least the superficial lobe, right? You will have the deep lobe here, but the superficial lobe outside, if you see outside, it's definitely a parotid. Okay, this one is parotid, superficial. This is submandibular. All right. And the next question, where you are given, there are multiple lesions in the small bones of the hand. I've mentioned many times in the bone tumors, whenever it is small bones of the hand, multiple lytic lesions, always think of enchondromas, right? Always think of enchondromas. When you have multiple lytic lesions in the small bones, it is enchondromatosis. Okay, it is enchondromatosis. That should always be in the differential. Okay, that should always be in the differential. All right. So yes, I believe that was the quick discussion of the radiology recall questions. Again, a disclaimer, this is not to make you realize, oh my God, you made a mistake. How could you get that wrong? It is to learn out of it so that in our practice also we learn this, and for the future aspirants to know that how the topics are repeated, how the options are tricky. It is mastering the previous year topics, which is very, very important to get a good rank. Anuja, I'll update that on soon, very soon. A bit caught up with some other commitments, but I'll let you know on the Telegram group for sure. All right. Thank you so much, everyone. Let me know if there are any other concerns, any suggestions in the recall, or anything else. Do let me know. I would be always available for each one of you. So goodbye, take care, and keep studying, keep revising, and keep winning. Let me see, just a second. Okay, Dr. Akash, trust me, even I'm missing each one of you, like, my old family members there. So even I miss you in my classes. Thank you so much, KGB. So I remember the septate uterus that has come, and we discussed just one day before the exam. Thank you so much, Dr. Akash, and hoping to help many other students in the coming days. All the FMG students, I'll be letting you know the plan for the FMG, what I would be planning by tomorrow on the Telegram group or in one of the YouTube live sessions. I'll let you know about that. Okay. Thank you so much. Goodbye. Take care and keep studying, keep revising.